So I am super excited to chat with today's guest. We have Dr. Jolene Brighten, and we're going to be talking about, sex, hormones, periods, of course, tying some of it into thyroid health. And so let me go ahead and dive into Dr. Jolene's impressive bio here. So, Dr. Jolene Brighten is a hormone expert, nutrition scientist, and thought leader in women's medicine. She is board certified in naturopathic endocrinology and trained in clinical sexology. Dr. Brighten is the author of Is This Normal? A non judgmental guide to creating hormone balance, eliminating unwanted symptoms, and building the sexual desire you crave. A fierce patient advocate and completely dedicated to uncovering the root cause of hormonal imbalances, Dr. Brighten empowers women worldwide to take control of their health and their hormones through her website and social media channels. Dr. Brighten is an international speaker, clinical educator, and medical advisor within the tech community. And thank you so much for joining us, Dr. Jolene.
Absolutely. I'm so glad to be here with you and everyone who's listening right now.
Yeah, and we were chatting a little bit before, I started recording this and I was telling you how I was listening to your audiobook of, Is This Normal? And really, really enjoyed it. I also let you know how my wife was, just, kind of not freaked out, but she was just surprised because again, you don't hold back in the book. I mean, you talk, about sex, you talk about orgasms, and again, we'll talk about some of that here, but again, really a very necessary book. And I guess so. What motivated you to write the book? And is this normal? Because you have another book prior to that, the pill book, which also was an amazing book. So yeah, let's if you could dive a little bit into that background.
Is This Normal was born out of all of the questions that I received. So many people not understanding their body, having received misinformation. We know social media is full of it when it comes to women's body. And really, my patients, my social media followers, everybody asking time and again, is this normal? But, there was that inspiration. That's actually how we arrived at the title. And when I look back at like, where did this really come from and what was it rooted in? Well, firstly, women know their bodies, they know they're normal. However, they haven't been given all of the tools, all of the information. And in fact, they've been given a lot of misinformation. So, sex education, we know when you look at the states in the United States, most of them are not teaching medically accurate sex ed. And at the same time, we're being told a lot of things like period pain is normal. Being tired is normal. I'm sure that you have a lot of people who have heard that, especially when it comes to thyroid disease, or that, the myriad of things that affect women, they're just chalked up as being normal. Yet when women say, I know my body, this isn't normal, they're often pushed back on. So I wanted to help answer the question of what's normal, what's not when it comes to our anatomy, when it comes to our hormones, when it comes to our sex life, and then also help people navigate finding their normal. Because as anybody knows who has taken a statistics class, normal exists within a bell-shaped curve. And right smack dab in the middle, that's where just like a lot of people are hanging out. And then you've got the outliers underneath. So you've got the distribution, right? The normal distribution. So normal is a gradient. And even when you get outside of that bell curve, and you will find that people are still normal, it just might be their normal. So I help people navigate all of that and really set it up as the book that if you were handed this from the day you got your period, you are less likely to experience medical gaslighting. You are less likely to struggle with your hormones. And you are certainly more likely to experience the pleasure that you're after in this life.
Okay, so everybody's normal is different, and then you also mentioned the book that people mistake common for normal, that that's just
Mhm.
because something is common doesn't mean it's normal. And people ask me all the time as well. They ask me, maybe not relation to, sex and orgasms. And I mean, sometimes it are hormones, but for so many different things. Is this normal? Is this normal? And I have to also say the same thing. It's common, but it doesn't mean it's normal. But you kind of just expanded on that. Maybe it is like someone's normal, but not necessarily normal for everyone.
Well, as you bring that up, I think right away about how period pain is chalked up to be normal. It's not normal. Period pain is not normal. It is common. I have been saying this for well over a decade. If you scroll my Instagram, you will see that, like, I mean, I was popping off about that like so long ago. And people really have challenged me. Doctors have challenged me and said, well, if it's not normal, then why do so many women have period pain? And I'm like, yeah, doctor, why don't you look it up? Like, what is going on here that is such a disservice to your patients? I think the other thing that, we do a big disservice in medicine when we mistake that what we see are sick people, right? Who comes to us, people who have problems, people who want problems fixed. And we mistake our experience of constantly seeing that, like, everybody has period pain as being something that must be normal because everybody has it. You have a bias in that. And in fact, we know from the research that because of this bias, because of the bias that exists in medicine that is against women and puts them at a disadvantage, something like period pain or pain with sex that just really gets dismissed or chalked up as normal is a big reason why it's estimated that, for the condition of endometriosis, 6 out of 10 never get the diagnosis. And in fact, it can go as far as 11 years for somebody to actually get the diagnosis. This is a condition that affects anywhere from 10 to 15% of women. And so I bring this up because I think it's important to understand that sometimes people are like, oh, well, like, what's the big deal? Like, why should we even care about this? This happens way too much in women's medicine. And it's because, like, in a case of endometriosis, this one example, a leading cause of infertility, something that can lead to gastrointestinal issues, problems that evolve with the bladder. So having actual lesions. So endometriosis is when tissues that are similar to the lining of your uterus, but not exact, exist outside of your uterus and they respond to estrogen. It is deemed a estrogen dominant condition because estrogen will stimulate the tissues to grow. And just like the lining of your uterus, they will bleed when you menstruate. And because of that, you can end up with strictures, so tightening of tissues, lesions that are very, very painful, and lots of inflammation. And that can affect your ability just to have a bowel movement every day.
And you said in the case of, on average, with endometriosis, it could take, how long did you say? Did you say like it could take up to like 10 years or longer to get
It can,
diagnosed?
yes, it can take up to 11 years. And when you consider the research says that only 6 out of 10 are actually getting the diagnosis, then you consider that those 6 may have had to go 11 years of going to their doctor saying, I have period pain. I have pain with sex. I have pain with urination. I have pain with my bowel movements. I have extreme bloating that is occurring around my period. This is something that you'll see a lot on the internet where people are like, it's, I don't know if you've seen this meme going around, but women are like, oh, all the hot girls have bloating. Hot girls have bloating. And I look at that as a practitioner. I'm like, wait, if you have bloating and it's that significant, some of these women are showing pictures of 4 to 6 months, pregnant looking bellies. Like, that's how bloated they're becoming. When you consider that, I'm like, hold up. This could be endometriosis, especially considering how long it takes to get the diagnosis, how misunderstood it is, and how many doctors are really dismissive of these things. As you know, working your patient population, if we see extreme bloating like that, that could also be small intestinal bacterial overgrowth. It could be something causing inflammation in the intestines. It could be related to thyroid disease and slow motility. So in anybody who says like hot girl, all the hot girls bloat, I'm like, pause, back it up, because that's not normal.
Yes. No, no, I'm glad you mentioned that. So you're not saying that endometriosis is the cause of all bloating, and same thing with period pain. If a woman has period pain, it doesn't necessarily mean they have endometriosis. It's just that it's commonly overlooked and commonly missed. And like you said, many doctors might say that period pain is normal, and maybe it is, or maybe it's not related to endometriosis. But again, the point is that they just dismiss it, and they do tell the person, do tell the patient that it is normal. And maybe the same goes with bloating and some of these other symptoms. So I mean, sticking with the topic of PMS and period pain, and then also like periods, like, some women have like heavy menstrual flow. So I mean, both. So again, I guess this is where we get into common versus normal. So because a lot of women do have some pain and cramping, and and some have a heavier flow. So in a perfect world, would you say then there would be no period pain and like just like a regular flow, or again, is some women's normal to have like a heavier flow and maybe some cramping, for example?
So the question is like, what is the flow, and what are we talking about here? So let's break down what a normal period should look like. So firstly, having some mild cramping, totally normal. Feeling a bit tired before your period, also normal. Feeling like you're totally wiped out, exhausted, never should be considered normal. If you are driven to have to take NSAIDs consistently every single period for multiple days on your period, that's not normal. Sometimes people will push back and say, well, everybody's pain tolerance is different. It doesn't matter. Your pain tolerance, like whether it's different than anyone else, doesn't matter if your period interferes with your activity of daily living. It causes you to vomit, to cry. You're having extreme diarrhea with it. These are signs that your prostaglandins can be really elevated. Prostaglandins are hormone like chemicals which stimulate the uterus contract. Very good thing until there's too many of them or they're super potent. So they also can be part of the inflammatory picture that we see with what people classify as the period flu. Period flu is feeling really achy, like you're getting sick, very fatigued before your period. That's not normal either. And I got more to say about the period, but just to jump in real quick, omega-3 fatty acids in the diet and increasing magnesium are two things that you can do to mitigate those prostaglandins and make an easier period. So I typically recommend that you start with diet first, but as you know, eating cold water fish consistently, throughout the week, getting enough magnesium rich foods, that can be a struggle for some people. So looking at something like 2000, so 1500 to 2000 milligrams of omega-3 fatty acids. You actually make prostaglandins from omega-3 fatty acids. That's why those are so important. And then anywhere from 150 to maybe 300 milligrams of magnesium. I like glycinate best because that helps women sleep as well. That can be really helpful to bring in and to help mitigate some of that pain. So I just wanted to give those solutions before I go further with the period talk. So with a period, the average cycle is going to fall 3 to 5 days. If it's less than 2 days, that's pointing to too little estrogen. And we can see that in late stage perimenopause. Late stage perimenopause, that is right before you move into menopause, totally normal for periods to kind of go all over the place, but also to have those shorter periods. If you are younger than 45, I always ask the question of like, before we just say, oh, it could be perimenopause, I always am like, well, could it be anything else going on? And is there anything we can do to help with that? If your period's going beyond 7 days, that can be problematic. And it is problematic. We get worried about that. That's too heavy of a period. Maybe estrogen is stimulating the endometrium too much. Maybe you have fibroids. Maybe you have adenomyosis, which is, as I explained in the book, a cousin of endometriosis. And you can see clots accompanying the menstrual cycle when you have adenomyosis. And I will say that condition is missed even more than endometriosis. And I talk about a lot of conditions that are missed in the book in order to help women advocate for themselves and have a more productive conversation with their doctor. Now, in terms of the flow, like how heavy should it be? Here's what's normal and not always talked about. So firstly, a period that starts and then kind of stops, that's normal. So maybe your period that you have it, you're like, oh, I'm starting to have a flow, several days. And then it's like, well, it's really tapered off. And then it makes an appearance the next day. That's not necessarily abnormal. Having a period flow that's so heavy that you need a super tampon and a pad, or you're changing a tampon or a pad every single hour. So I'm not talking about a tampon and a light day. I'm talking about a tampon and a pad because the flow is so heavy. It's the only way to contain it. If you're changing the one of those products every hour. If you have to wake up in the middle of the night because the flow is so heavy, you have to change those products. This is too heavy. And I have billions of checklists, it feels like, in the book, but I have a whole checklist on like what's not normal for your period, what is normal. But it's important to understand what these parameters are, because like I said, your period might be 3 days up to 6 days, and that's all considered normal. But when we have these outliers, we need to investigate what's going on. So we've talked about period pain. We've talked about the period itself. I'd like to talk about cycle length. You good with that?
Yes,
Okay,
definitely.
cool. So, because this is another one people are really confused about, where they're like, well, my period has always come 24 days, and isn't a 28-day cycle the norm? Very few people are having a predictable 28-day cycle regularly. We set it up as a way to teach about the menstrual cycle. And, there is some science to support, like there's these averages of how long the luteal phase can last and how long it should last and when ovulation might happen. But the myth of the 28-day cycle has also lended itself to the myth of everybody ovulates on day 14. And none of that is true. You might even ovulate 1 month on day 13 and the next month on day 15. But it shouldn't be that you ovulate 1 month on day 10 and the next month on day 28. And your cycle shouldn't be something that is less than 21 days or greater than 35 days. And I will say, even though I say that, if you consistently have had a 38-day cycle your entire life and you've been worked up and nothing's going on, then that is your normal. But when in medicine, if you're going beyond 35 days, we need to investigate things like polycystic ovarian syndrome, or PCOS. There's all other conditions as well, but PCOS is far more common than those. And if your cycle length suddenly changes, we need to look at, could this possibly be hypothyroidism? Changes in the menstrual cycle are one of the most missed symptoms when it comes to hypothyroidism in my experience. And that's because clinicians are trained to put someone on the pill when the cycles become irregular rather than test and understand what's going on. Unless the caveat being you want to have a baby, then you might get that thyroid panel. So when it comes to the cycle length, that should be pretty predictable within a few days of itself. So it's not abnormal if you did have 27 days and 29 days cycles, but it is abnormal if there is a change in what's been your normal, or you are less than 21 or greater than 35. And if you never know when your cycle's showing up, you definitely need to see a provider.
All right. Yeah. And I should say, I see a lot of people with hyperthyroidism as well, which could
Yeah.
also impact the cycle. So whether it's, and in different ways too, I can't say there's a consistent pattern. I mean, some people will completely stop cycling for a few months. Sometimes it
Mhm.
might be more, more frequent as far as when they're dealing with hyperthyroidism, including Graves' disease. But yeah, so regardless of whether someone has hypo or hyperthyroidism could impact. And like you said, a lot, especially in the case of hypothyroidism, a lot of times it's missed, and and
Yeah.
doctors will look at other things. So thank you for sharing that.
Totally. And I
And
just want to say that I see the
mhm,
same thing with any thyroid disease, is that sometimes the cycle stops, sometimes it becomes irregular, sometimes the periods become very long. So that is something that should always be ruled out. And most people are not aware of this, and you may be, but I definitely want your audience to understand that when it comes to follicular development, this is how we get a mature egg that we then ovulate. That is very, very dependent on the thyroid hormones being optimized. And this, if you want to have a baby, absolutely crucial. If you don't want to have a baby, absolutely crucial, because only by ovulation do we get the progesterone levels that we need. But what is interesting is that, I mean, you've been in the thyroid space for a long time. And most doctors are going to just check a free T4. Then you get to functional medicine. We're looking at a free T3. And we've got those patients who just do better on natural desiccated thyroid hormone, which we know also contains T2. And I have always said the body doesn't do something for nothing. Like if it's still making these hormones, there's a reason. And what's interesting is when you look at the research, T2 is actually involved in that follicular development and interaction with the mitochondria, which are really tending to the health, the quality of the eggs, and the health of the ovary overall. So thyroid health directly impacts ovarian health. And this is so crucial not just for pregnancy, but in the longevity conversation, because the longer we can have our own natural hormones taking care of us, the less risk we are for things like dementia, cardiovascular disease, osteoporosis, type 2 diabetes. I could keep going. Take care of your thyroid, your mitochondria, and that is one key to taking care of your ovaries.
So, based on what you just said, if someone is taking, levothyroxine, synthetic T4, and if they are having fertility issues, again, not to say it's definitely related to that, but it could be just because when they're taking T4, they're obviously missing out on the T2. I mean, and they're hoping that'll convert into T3.
Yeah, the hope, right? Of like, will it convert? So, unless your thyroid, unless your post thyroidectomy, your thyroid's been removed, your thyroid is still going to make some T2. It's going to put along. It's going to do that. What we do understand really well from the research is that T4 is absolutely crucial, not just in follicular development, in that egg health, but also preventing miscarriage, for baby getting that. The long-term studies that have looked at when mom had insufficient T4 showed that even these children, they followed this cohort up to 16 years of age, and they were behind in terms of cognition and motor skills. So we know it has a tremendous impact on fetal growth and development. And so for anyone listening, if you're like, why is my doctor giving me T4? Because T4 crosses the placenta. And there's this magic thing that happens in medicine where as soon as you become pregnant, you just become the thing that's carrying the baby, in the way of the baby, and everybody's focused on the baby. And they forget that, like, yeah, your health and well-being matter as well. I say that kind of backhandedly. We know there's great providers out there, but we also know that the United States is we're at the bottom. We rank bottom when it comes to maternal fetal outcomes. When it comes to obstetric violence, we win at that. We're not doing well as a developed nation. And so I just want people to understand that if you have a great provider, yay, celebrate it. Maybe share it in the comments. That would be really great if you share it in the comments with other people. And if you don't have a great provider and you feel like it's just you, it is not just you. But back to your point, I just want to say something that's been, very interesting that I have observed and used in my clinical experience is that women who aren't necessarily presenting with hypothyroidism, but they're going through IVF, sometimes giving as like a very low dose, like 25 micrograms of levothyroxine, can actually improve the outcomes of IVF. Do I have great studies that I can tell you about that? No. But when we see things like, hey, that free T4, it's like hanging around 1. Sometimes it drops below 1. Ideally we want that 1.2, 1.4. That's somewhere where it's like, let's just try. We're only going to do it for 1 cycle. That's only going to be a few weeks to like support you. You're not going to have hyperthyroid symptoms from that. And I've actually seen some pretty good outcomes. So take that clinical pearl, people, for what it's worth, and discuss it with your provider.
All right. Now, that was awesome information. Thanks for sharing that. Low sex drive, low libido, something else that maybe practitioners in general, maybe not functional medicine practitioners, but medical practitioners would say is normal, but more common. So, why is that so common? What are some of the underlying causes?
Okay, so hypothyroidism and hyperthyroidism. Oh man, the way your nerves are so graded in hyperthyroidism, like good luck getting in the mood, right? That can just be really hard. So, but to answer your question, why is it that so many women go to their provider and say, I'm struggling with low libido, and their provider's like, well, you were born with ovaries. That's just normal. Well, really, and I break this down in, is this normal? If we go back and we look at the history of medicine has essentially said we have this male component. That is the standard. That is perfection. We will measure everything against this. And this, like, in, other inferior model over here with baby making accessories, like that one should match, right? And so everything is through the lens of men. And with that lens, the myth, and I say this is a myth because I think it's unfair pressure that society puts on men, that men are always in the mood. Men always want sex. And Men have more testosterone that they're using at a cellular level. Therefore, testosterone is the key hormone driving it. And, that's men are always in the mood. And what we understand, okay, firstly, is that for women, it's not just testosterone, there's an estrogen component as well that's really important in terms of your desire, your ability to self-lubricate. And at the same time, all the other hormones matter as well, along with stress hormones. And this stress hormone picture that I'm talking about, and thyroid and insulin, this applies to all bodies. Okay. Doesn't matter if it's ovaries or testes, all bodies are affected by these hormones, and it can affect their desire. Now, when we look at the research and we look at, okay, psychologically, like, are there these differences going on? What we understand is that there are more women who will identify with what's called responsive desire. And that's where you talk about, like, you got to get in things going to, like, get things going. Like, it's like you're not in the mood for sex until you've actually started foreplay. That is normal. It's called responsive desire, and both men and women can experience that. And then what we have is spontaneous desire, which is what the media shows us that all men should be like, which is, they just always want sex. Sex is always on the brain. They always are chasing tails, so to speak. And in reality, that spontaneous desire, that isn't something that every man experiences, and women do experience it. But when women experience it, they're often told things like, oh, you have this sex drive of a teenage boy. Like, you are more like a man. And really, when you stand back, this is just a misframing and misunderstanding that men are supposed to be one way and women are supposed to be another way. And it's just absolutely not true. And I talk about in the book the clitoral conspiracy of how everybody's heard, like, the clitoris was discovered in the 1990s. Lies. No, it wasn't. It was discovered a very long time ago. And it was actually, in French, the translation is shameful member. So what does that tell you right there? It was something to be shameful of. And they cut it out of anatomy textbooks. Even to this day, the majority of medical anatomy, this means the books your doctor is learning from, do not have medically accurate illustrations of the clitoris, which is why in Is This Normal? You will find 3. I put 3 in there, and I'm like, if nothing else, y'all are going to know more than what your doctor knows about the clitoris. So I've talked about, we've got the component of the different ways that sexual desire can work, the responsive and the spontaneous sexual desire, the idea that women have to be different, and that if it's a problem, it's got to be testosterone, and that we don't know about the clitoris, right? A lot of people don't. My necklace, you can't see it behind the mic. It actually says clitorate, which is a term that Ian Kern coined to just talk about, like, being actually literate about the clitoris. And then we've got a whole other component about it's called the dual control model, which is all about things that turn us on, things that turn us off. And this was research done by Bancroft and Jansen to first understand men. And so if everybody's listening, they're like, well, she's in women's health, why is she talking about men? Because I think it's so important that we understand that these experiences are universal and that there is a lot of similarity. Although I did tell you with hormones, it can be different with women. I'm going to talk about that a little bit more. So the similarity being that our nervous system has to be ready and tuned to accept the sexual inputs. And those are the accelerators. And if we have too many brake pedals on, those are things like stressing about our body image, stressing about unintended pregnancy, stressing about our relationship, like a lot of stress is what you're hearing. That is going to basically create a nervous system chaos in which you cannot receive the signals that maybe your partner's trying to throw your way. And in those instances, it's also another time to feel like, why am I out of the mood? Now, when I talk about stress and I talk about women, I want people to understand that the female body is more attuned to the stressors of the environment, because biologically speaking, Whether or not you want a baby, whether or not you can have a baby, biologically speaking, the tissues, the cells, everything about your being is set up to survey whether it's safe or not to have a baby. And so if it's not safe, right, you've got to like, let's just face it, babies are noisy. All right. They're going to give away. You're like hiding from a predator. They're going to give you away. It's like my biggest fear. Like, what if there was a zombie apocalypse and I have a baby or I'm pregnant? How am I going to outrun a zombie? Like, I don't know how I'm going to do that. Like, and so, that's just like, that's like way out there. But if it's a different kind of predator, like the real kind, like a tiger, okay, then like how are you going to do that? The body knows. The body is inherently wise. So if you are your doctor said eat right and exercise, you just need to eat less, move more, and you're doing that, and now you're like, I'm never in the mood. That's because that's a negative input on the system. You just told your body the environment's not safe, it doesn't have enough food. And so we have to understand that these different types of stressors will cause biological shifts in our hormones that can impact our sexual desire. Why impacting our sexual desire? Our ability to get in the mood. Because the safest way to live your life in moments that are high stress is to protect you from not becoming pregnant, which means you have no interest in having sex. Does that all make sense?
Yeah, it definitely makes sense. So does this relate in like functional medicine? They talk about the pregnenolone steal, cortisol steal, where the body's prioritizing cortisol production at the expense of DHEA and the sex hormones. So is that
I'm so
kind of what you're
glad that
talking
you
about?
brought that up. Yeah. So, pregnenolone steal is an outdated way to think about it. And so I just want to bring that you're like I'm not like shaming you or scolding you for saying that, because if you ever learned about it back when we learned about it, that's how we talked about it, was the pregnenolone steal, was this idea that pregnenolone, the mama hormone, like she's given birth to cortisol and progesterone, but in that moment she's like, I got to birth more cortisol, forget the progesterone, and there's nothing left over. And now that we have more research understanding the mitochondria and how this is all working, what's actually happening is the master orchestrator of hormones, that is your pituitary, your hypothalamic pituitary axis of wherever it goes, right? Whether it's the adrenal axis, the ovarian axis, ovarian, adrenal, thyroid axis, that is orchestrating things to say, let's get cortisol up. Let's make sure we're dampening down progesterone. And in the book, I have a whole diagram of how stress affects you. Because I think too often as doctors, we say, oh, you need to work on your stress. You like, and in functional medicine, we don't do it like that. But the average woman or the average provider's visit that the woman is experiencing, she may go in and they're going to say, you just need to get a handle on your stress. Well, why? And what does that even mean? What does that do? Well, as stress goes up, we know cortisol production goes up and ovarian function goes down. So it's not just progesterone, but it's all of the cycle can be impacted. And in extreme stress, like hypothalamic amenorrhea, we see that you will lose your period. And that is, you are not getting enough calories, you are over exercising. And anyone who has ever had a significant life stressor, like your dog dies, somebody close to you passes away, maybe you were in a car accident and you miss your period, that's actually normal. Your body was like, hold up. Survival will always come before procreation, and your body is shifting in a way to protect you. And that's what I think functional medicine does a lot different, is we stand back and we ask why. Why would your body choose to take this path rather than trying to strong arm the body into submission and be like, body, you're misbehaving. I'm going to give you a medication. I'm going to suppress that, going to do these things. And listen, sometimes we need medications. However, even when we need a medication, we still need to ask why. Why did the dysfunction develop? And I say dysfunction as in, if you are not menstruating, you're not therefore not ovulating regularly, and you should be, something has become dysfunctional in the system. The adaptation, which is meant to keep you alive, is adapted too far. You've adapted too close to the sun, friends. You're burning up. Like, what is happening here? And so we have to ask the question, why did this happen? Why did this shift happen? And work at that level.
All right. Well, no, thanks for sharing that. And yeah, just all this is really fascinating. Uh, Definitely want to talk about orgasms, because I don't think we've spoken. Well, I'm 100% sure I've not spoken about this on the,
Everyone wants to talk about
yeah,
orgasms.
yeah. Exactly. So, and obviously there's going to be overlap too. I mean, there's going to be, it's going to be related to in many people. Thyroid health is going to play a role. The stress hormones like cortisol, but there's also going to be some psychological aspects as well. So yeah, let's talk more about orgasms. Why, like why Oh, actually, one more thing before we get into orgasms, and if this is going to take long, we could skip over this. But every now and then, there'll be someone who has a heightened libido. Like, I see,
Mhm.
so what would be the cause of like having too high of a libido?
There's no such thing as too high of a libido. That is your normal. So that when we say somebody's libido is too high, what we're really saying is that they have spontaneous desire. That's their MO, right? That's the mode that they're activated on and that they're going through life. And so that is completely normal. I think we get in trouble when we start pathologizing what is normal, and that is definitely one of those instances where people are like your sex drive is just too high. And the other thing that happens sometimes in those situations is that person's their default of when they're stressed is actually to have desire. That's not as common to be in the mood when you're stressed, but I think those people's biology are really hip to the fact that the orgasm that we're going to talk about is going to release oxytocin, which combats cortisol's negative effect. So cortisol will not only aid you in what you can see, but cortisol will aid you at the cellular level. If you are exposed to chronic stress, we know the brain suffers significantly. You can have memory deficits, cognitive deficits. And so, with that, orgasms can actually help and bring on the oxytocin. These people will also get, and this is what everybody gets, right? When they're intimate, is the connection. And that connection, that intimacy, that act of mindfulness, which if you want to have an orgasm, it is an act of mindfulness. You have to be present in your body to even arrive there. Those things we know help stress. If it was outside of sex, it would help stress. But so sometimes that's also where people are like, something's wrong with you because you want to have sex when you're stressed. And it's because something about there being knows that like these are all the things I can check so many boxes with this that are going to be helping me drop my stress quickly and optimizing my hormones.
Okay. All right. So yeah, talking more about orgasms. Let's get into like a question I have with orgasms then, like, is it normal as you get older? Like, I'm in my 50s, but even like beyond that, like 60s, 70s, you're gonna have natural decreases in the hormones. Can someone in their, 70s, 80s expect to have orgasms like they would in, their 20s and 30s, or even again, people in their 50s, or should they expect a decline where maybe they could still get an orgasm as they get older, but not, it's more challenging? Or is it just because of what we've been discussing as far as, well, if the older people get, like again, they're more likely to have some of these other health issues develop, and and maybe some people have them for years, like Hashimoto's could be undiagnosed for like 10, 15 years. And anyway, I'll stop rambling and I'll have you
Yeah, yeah.
talk about orgasms.
When I tell you how rampant STIs are in nursing homes, that's all I got to say. That no, you shouldn't just be losing your ability to orgasm because you are aging. Now, as you brought up the case of Hashimoto's, hypothyroidism, long term undiagnosed, that's going to affect the cardiovascular system. Anything that negatively impacts the cardiovascular system or our blood glucose, our blood sugar, and our insulin levels, that can impact your ability to orgasm. Now, as we get older, we are at higher risk of developing diabetes and having circulatory issues. Now, when we look back at the research, and most of it has been done on men, shocker, I know, because if a man can't have an erection, it's like stop everything. Like we have to figure out what's going on. And I think that's a very good thing. We should also apply that to women. Now, the clitoris and the penis are the exact same embryological tissue. When you're an embryo, you get this hormone that it's called testosterone that comes through, and if you've got a Y chromosome with the right genes, then you have a penis, you have scrotum, you have testes. And if you don't, you have a labia, you have a clitoris, and I outline all of this in the book. The clitoris and the tissue, or excuse me, the clitoris and the penis, same tissues, get erections. And erections require nitric oxide, which we know those pathways can slow as we age. They also require good blood flow and circulation. And something that we know that is affecting far too many people in the United States that can impact our clitoral health, our penile health, is diabetes. And so it's been that if you have somebody with erectile dysfunction, you need to look at their cardiovascular health, you need to look at diabetes. This is what I was taught in my nutrition science classes 20 years ago. The same is true for the clitoris. So if somebody starts complaining of inability to orgasm, simplest thing is that I like to validate it that yeah, it can sometimes be a struggle for a lot of different reasons. But getting older isn't a death sentence for your sex life. And in fact, many women who are postmenopausal report having much better sex, 50 years plus, than their 20 something self. Part of it is sure you're more comfortable with your body. Others is, it's experience and you understand your body more. But it's also the threat of an unintended pregnancy, which can mess with your nervous system, pull you out of the mood, is no longer there. And they're finding that they do orgasm better. They have a much better sex life. So I want people to understand that. Not a death sentence. And if you're starting to struggle, definitely get that investigated, get it looked into because something else might be going on. Now, the other piece that I want to say about, sex as you age is lubrication is a must. If you are not having adequate lubrication, which is estrogen dips during certain times of your cycle or postmenopausal, then you're going to need more lubrication. And that is absolutely normal as well. And, I said that was the last thing I was going to say. I'm going to say one more thing about orgasms. The research tells us that only about 18% of women report being able to orgasm by vaginal penetration alone. And that is based on their anatomy. Their ability to do that is based on their anatomy. Predetermined, nothing they can control. It's just the distance of where's the clitoris, where's the vagina. And so this is important for people to understand because it may very well be you need more clitoral stimulation in order to reach an orgasm, and that is completely normal.
So like more foreplay, you're saying, or
Yeah, so,
or
I talk
as an
about
example, at least, yeah.
yeah. No, I appreciate this because I talk about in the book about foreplay. So using the word foreplay, like we all know what that means. And I love common language so that we can arrive at the same place and start to understand that. We have to also recognize that foreplay is actually sex and that it can be totally gratifying and you can achieve an orgasm. By the way, when you ask people, hey, remember your best sex of your life and tell us like what made it the best sex, they don't often report orgasm. I want people to understand that as well. Best sex of your life, people say things like intimacy, connection, vulnerability. They don't say orgasm, but we put so much emphasis on the orgasm. And as a hormone doctor, I do think hormone or like having an orgasm is great. And if you can't, we should investigate things, but understand that like every sexual adventure, you're not going to hit an orgasm. And you may hit your orgasm in foreplay and decide not to have penetration if you're in a heterosexual relationship. Or you might hit it in foreplay, have penetration, and hit it again. It's totally up to you. But when we use the word foreplay, I never want people to feel the pressure. And I want to just acknowledge the pressure that foreplay, it's set as to most people in their minds, this is the stuff that happens before. It's not the main event, but it can totally be the main event. And so when it comes to clitoral stimulation, that can happen on its own, or it can happen in conjunction with a partner and having vaginal penetration at the same time. But the clitoris, I list in my book, there's a lot of ways to reach an orgasm. There are people who it's like documented, like thinking off, like people can just think about it and they can have an orgasm. There are people that, they go to the gym and they work out and they randomly have an orgasm. It's called a coregasm. They're working their abs and they're like, I did not intend for this to happen. So there are a lot of ways to arrive there. However, the majority of people are going to arrive there via the clitoris. And the clitoris, because it is not on the outside like the penis, And because it doesn't have to also pass urine and ejaculate, the penis has a lot of jobs to do. The clitoris has one, and that is provide pleasure. And because the clitoral structure, what you see on the outside, just the tip of the iceberg, the clitoral structure actually extends inside. And because of that, it can be more sensitive because it is more protected. It's not being stimulated all the time. And it in fact is. And those neuronal pathways are the primary way that people orgasm. In the book, I also talk about people who have spinal cord injuries and how they find new ways to orgasm, because the body, this is how important pleasure is. And I think, if somebody's like tuning out right now or their doctor's dismissing them, understand that the pleasure of being a human is so important that if you have a spinal cord injury, that pathway that went to the penis or to the clitoris, those nerves will set up other places. And now people are noticing that, like, oh, I can be stimulated on this other area of my body and achieve an orgasm. And I want people to understand that that is because the brain is set up to be the big sex center, and it sends out those nerves seeking out pleasure. And so your body thinks it's important. The World Health Organization thinks it's important. The research says it's important. This is not something we should take for granted.
All right. Well, yeah. Thank you so much for sharing that. Yeah, definitely a lot more in the book. So, yeah, I highly recommend, everyone either reading it or listening to the audiobook version like I did. So I have two quick questions, but they might not be two quick answers. So if you don't have
I'm gonna
time,
try. I'm
again,
gonna do it.
okay.
I talk a
Just
lot.
because
I
yeah,
get excited.
just because nobody has spoken about the vaginal microbiome. So the first
Yeah.
question is if you could just briefly talk a little bit about how, like, the vaginal microbiome and how to support it, and then just briefly talk about your 28-day plan, because I know people will have to read, the book, or again listen to it, because there's no way you could talk about the whole 28-day plan in just like a, couple of minutes. But can you touch upon those two things before we wrap it up?
Yeah, I just want to say I have ADHD. I write my books for brains with ADHD that you never have to read it front to back. You can jump in anywhere you want and you will still get what you need out of it. And same with the plan. If you want to just jump into the plan, you can just do that. And while you're going, go back and read it as you go. So you wanted me to talk about the 28-day plan, but before we get there, I want to get into the vaginal microbiome. So the vaginal microbiome, everybody needs to understand, it's not just the vaginal microbiome. There's a cervical microbiome, there's an endometrial microbiome, there's a tubal microbiome, there's ovarian microbiome. These microbes are everywhere. And I talk all about it in the book. The biggest thing I think that women need to understand is that your estrogen matters so greatly to the health of your entire microbiome, your skin, your gut. As you enter menopause, we see that microbial diversity drops as estrogen drops. Your estrogen is so important, and your vaginal microbiome is no different. Estrogen stimulates the cells that produce the glycogen, that's the sugar that feeds the lactobacilli in the vagina. Lactobacilli are why you have a pH that keeps yeast in check, it keeps BV out, and helps protect against other pathogens. So taking care of your estrogen, as I outline in the book, is absolutely essential to taking care of your vaginal microbiome. And I have an entire chapter about discharge and talking about BV, yeast infections, other types of infections as well, but what you can do naturally to be working on that every day to optimize your vaginal microbiome. I think we're going to find in the future, as it relates to cancers, that there is a link to what's happening in the microbiome there, not just by way of hormones, but also the inflammatory processes that can occur. And that's probably going to be like when I'm well into menopause. So don't wait on the research, like just start taking care of your body now in the common sense ways that maybe your mama already taught you and that the new science is showing you that I talk about in the book. 28-day program, that is where we are going to get into how to optimize your hormones and how to understand your normal when it comes to sex throughout your cycle. And I designed the program so you can just do the hormone thing if you want, Or you can also bring the sex stuff along too, so that you can understand your normal. Rather, I mean, the thing about libido and orgasms, like we don't go to our neighbors and we're not like, oh, what is your, like, let me compare my sleep to you and then judge and shame myself for it. Or like, are you talking to them about like their periods and then feeling shame and judgment? You are not. But when it comes to libido and orgasms, we often compare ourselves to others and then think something is wrong with us. And odds are there's absolutely nothing wrong with you. We need to help you discover your normal. And when you know that normal, you can get the pleasure that you want and also enjoy the hormone benefits that come along with it.
All right. Well, thank you. Thanks for again discussing briefly the vaginal microbiome, the 28-day plan. Definitely, yeah, definitely go. I mean, again, I was listening to it, and I think you have two. Do you have two chapters? I think dedicated to the 28-day plan. Like it was a quite a while. Like again, it was in great detail. It's not like just spending like five,
Yeah,
10 minutes on it.
I love, there's been people that are like, yeah, I got the audiobook and that I just could, I like needed the real book to see the checklist, to see the charts, like to go through the plan. And it's a very interesting book because so many people have said they're listening to the audio and they've got the physical book and they're looking at it as well. I'm like, that's so interesting to me. That's how I usually do things. But with the 28-day plan, there's a chapter setting it up so that you understand the why, the how, what to be tracking, all of that. And then there's the plan of like, let's just get in and let's do it. And I separate it that way because I think it can just become way too much information when it's like, you're doing the plan and I'm explaining to you all the reasons why you're doing the plan. And here's the next step of the plan. And I'm explaining all that. I'm like, I'll explain it. But some people are like, I don't even want the explanation. Like, I'm gonna just do this thing.
All right. Well, where could people get the book? I mean, should they go to your website? Should they go to Amazon like I did, or yeah? And anything else you'd like to share? Social media, the resources as well.
Yeah. Well, if you go to drbrighten.com, drbrighten.com/ITN dash resources, that's is this normal resources, there is a 4-week meal plan, recipe guide for you to help you optimize your hormones. And we've got other bonuses and goodies there. It goes along with the book really well. So you can grab it now, pick up the book later, and you can get the book anywhere that books are sold, really. Of course, most people use Amazon. You can request it at your local bookstore, call your library about it. And then drbrighten.com also has the book, but we rarely ever can outcompete Amazon. Just be honest there.
Okay, and then you're on social media, so I'll make sure I include the links to Instagram. You're on TikTok as well.
Instagram, TikTok, YouTube, Threads. Yeah, at Dr. Jolene Brighten.
All right, wonderful. Well, thank you so much, Dr. Jolene. Again, it was awesome listening to your book, and it was awesome chatting with you about your book. And I'm sure the listeners learned a lot, and yeah, I definitely did as well.
Awesome. Well, thank you so much. It was so great to see you again.
Yeah, same here. You take care.
You too. Bye.
Thank you. Bye.